Pattern of exam changed, type of questions changed. When everyone are going forward in the competition along with the change in the trend, what am I doing here? Thinking about how to solve a clinical MCQ? When we know that NEET paper will have 70% clinical questions and we started orienting ourselves studying clinically, but yet we find difficulty in solving the clinical MCQ. We make a lot of mistakes with the clinical areas. But can I say something? Solving a clinical MCQ is actually easy when compared to solving a MCQ which is fact-based. You don't believe me, right? Then this video is for you guys, the art of solving a clinical MCQ. In this video, I will detail you how to solve a clinical MCQ just like that. And I'm pretty sure that at the end of the video, your perception towards a clinical MCQ will definitely change. So stay with me till the end. But before that, don't forget to subscribe to my channel because this March month is going to be a golden time for you on my channel. Exciting stuff is coming, everything related to change pattern of NEET exam. So go subscribe to my channel DrJT and also click bell icon for notifications. And without any delay, let's learn the art of solving a clinical MCQ. Hey guys, if you're new here, this is DrJT, General Medicine Resident and a part-time YouTuber, and I welcome you to my channel DrJT. Did you guys got the PDF to my high yield digitalized stick notes which will really help you during the last minute revision? The link to download the stick notes PDF is given below. Go get them, make your revision much better. And also I have provided 1900 high yield points from all the 19 subjects. You can get them by clicking the links given in the description, and also do follow me on my Instagram as I will be posting short notes of the topics that are important for NEET PG. So in this video, I'm going to briefly tell you about how your mind should work while cracking a clinical MCQ, by what method you need to solve them, and what mistakes you are doing while practicing them. So I will do this by taking 2 clinical MCQs and explain you. One line that should strike into your mind while doing a clinical MCQ is, if your brain doesn't know, your eyes can't see. That means you need to be thorough with your notes, the theory part. You should be understanding the clinical aspect from that topic, and you yourself should build a clinical scenario while studying that topic. That's when your brain thinks sharp while solving the clinical MCQ in the exam. So now let me show you how I approach towards a clinical MCQ. Let's change the place. Okay, let's look into this MCQ. When you see this MCQ, more than 70% of the people will have in their mind is, oh my god, such a big question. Gone. Definitely I'll make a mistake. Suddenly all your energy will be drained seeing such a big question, isn't it? Don't have such a negative approach towards a clinical MCQ. Because you know the beauty of a clinical MCQ, the answer lies in the question itself. For example, if you take a memory-based question or a fact-based question, you need to think and struggle for the answer. But in a clinical question, it's in the question, it's in between the lines. That's why I said, if your brain doesn't know, your eyes can't see. So the next point while you solve a clinical MCQ is that you need to close your options with your hand before you read the question. Because many of you have a habit of reading the options first and then you read the questions. This leads to you getting biased, or you will get confused even though you have a clarity in the concepts. That's why close the options first, then read the question. The next point is, while you read the question, you need to read it out loud. Yes, you heard it right. You need to read it out loud, because if you read just looking at it, then definitely after 4 or 5 lines, you will forget what you have read in that 4 to 5 lines. Obviously, you will lose the track of the question. But when you read out loud, your brain catches few points which are very essential to solve that clinical MCQ. But I know many of you solve the MCQs and also grand test in your reading rooms, which is not usually possible to read out the question out loud. So whisper to yourself that is audible only to your mind and you. That will really help you in solving the MCQ. This will also help you to stay concentrated while solving the clinical MCQ all through the time. So I am reading this question out loud. An 80-year-old woman presents to her general practitioner with pain and swelling in the left knee. The pain began 2 days previously, and she says the knee is now hot, swollen and painful on movement. In the past, she has history of mild osteoarthritis of the hips. She has occasional heartburn and indigestion. She had health checkup 6 months previously and she was told that everything was fine except for some elevation of her blood pressure, which was 172 by 102 mmHg. Her creatinine level, which was around the upper limit of normal, the blood pressure was checked several times over the next 4 weeks and found to be persistently elevated. And she was started on treatment with 2.5 mg bendraflumetazide. The last blood pressure reading was 138 by 84. There is no relevant family history. She has never smoked and her alcohol consumption averages 4 times per week. And she takes occasional paracetamol for her pain. After you read the history itself, you need to pick some clickbait points. What are those clickbait points? Those are the ones that will lead you to the diagnosis or the answer. So what are the points that I have picked here? That is the pain and swelling in the left knee. Pain began 2 days previously. She says that knee is now hot, swollen and painful on movement. And she's old history of mild osteoarthritis to hips, and she's a hypertensive of 172 by 102 mmHg, and she's on treatment for 2.5 mg bendraflumetazide, which is a thiazide diuretic, which she was put on recently. So these are the main points that I need to catch in order to go further for the diagnosis. But rest of the thing, you need not bother. You need not take that into your mind and waste time. So after reading the entire question and also getting the clickbait points, you might have 1 or 2 answers in your mind. But if you don't have, also not a problem, because that is the essence of a clinical MCQ. You might get the answer in the history itself. If not, you might get it in the examination. If not, you might get it in the investigations. You might get it in the image itself. So some might have studied the investigations while reading their notes, or some might have studied examination, or some might have looked at the image properly, so that at any place you might get that clue and you might find the answer. So let me go into the examination. Her blood pressure is 142 by 86, temperature is 37.5 degrees C, pulse is 88 per minute. She is having grade 2 hypertensive retinopathy and her CVS and respiratory examination is normal, and she is having Hubbard nodes over the distal interphalangeal joints, which suggests that she is a known patient of osteoarthritis since long time. And the left knee is hot, swollen with evidence of effusion in the joint with a positive patellar tap and pain on flexion. So in the history and examination, they have been talking constantly about only one joint being affected. So immediately I will get into my mind is about acute monoarthritis. Right. So acute monoarthritis is a diagnosis, but we have differential diagnosis in that acute monoarthritis. What are those? Septic arthritis, gout and pseudogout. Probably any of these 3 will be my answer. So what are the investigations that they have given which will suggest that the answer is any of that 3? Let's look into it. Hemoglobin 12.1, white blood cell count is 12.4, platelets 384 into 10 power 9, ESR is 48 elevated, sodium 136, potassium 3.6, urea 7.3 elevated, creatinine 116, glucose is 10.8 elevated. So the patient is having a white blood cell count increase, ESR elevated and urea elevated, and she's having hyperglycemic. So whenever there is hyperuricemia in the patient, it clearly indicates for you the one diagnosis, that is gout. Okay, but let's look into the options now. Did they give gout? Now is the time to look into the options. Yes, they have given gout as option B, but they also gave acute osteoarthritis and they have given septic arthritis and renal osteodystrophy. Can I tell you a point here? The option A and B will be a trap for you, which is created by the examiner. Why is it a trap? Because already in the question they have mentioned osteoarthritis, and now you might feel they have given A or acute osteoarthritis, maybe it has exaggerated and you will definitely mark it as acute osteoarthritis. But the clickbait point is only one joint being involved. So it's not acute osteoarthritis. Now I am excluding it. And the next option, renal osteodystrophy, is also a trap for you, because in the question they have mentioned about her creatinine level being abnormal and she's also hypertensive, and in the investigations urea being abnormal. Many might get deviated and they might think yes, they are linking bone and the renal system and they might put renal osteodystrophy. But you can exclude this by looking at the X-ray they have given. In a renal osteodystrophy patient, the X-ray won't be like this, because in a renal osteodystrophy, the activity of osteoclast will be increased and those osteoclasts will lead to bone resorption, resulting in the thinning of the bone. Can we see any thinning of the bone? No, I can't see anything. But what features can we see in this X-ray? That will suggest either it is gout or septic arthritis. This X-ray almost seems normal, except that there is mild decrease in the joint space on the medial side of the both sides of the bone. So the next thing is we can eliminate renal osteodystrophy, as I said. Now we are left with gout and septic arthritis. In gout, there will be hyperuricemia and there will be elevated ESR, and the patient will have only one joint involvement. In septic arthritis, there might be increase in ESR, and increase in WBC, but X-ray again gives a clue that septic arthritis X-ray won't be like this. The joint has erosions around the cartilage and around the joint, which we can't see here. So we can clearly exclude septic arthritis also. In a case of acute gout, the X-ray almost looks normal. And why is this patient is having hyperuricemia and hyperglycemia, which led to gout? If you observe, there is the drug that is called 2.5 mg bentriflumetazide thiazide diuretics. Most common side effect is hyperglycemia, hyperuricemia, hypokalemia and hyponatremia. Hypokalemia and hyponatremia, here if you observe, the potassium and sodium are in the lower side. So the drug thiazide diuretic is the culprit here for causing the gout. That is why I said when you study pharmacology and medicine or physiology and pathology, you need to study integrated so that you will get a clinical diagnosis very simply and you can solve the clinical MCQs just like that. So our answer is gout. So in the next slide, I am going to show you the differential diagnosis, what I thought in the beginning about acute monoarthritis and how I did this excluding and decoding method of answering the MCQ. Remember, whenever you don't find the answer in the question or in the examination, you need to go by excluding and decoding method. Go for the options and then look what is fitting and what is not fitting and exclude and make a right answer. So this is the image which is showing one joint being inflamed and swollen, which is classically seen in acute gout. And in the second image, if you clearly observe, I can clearly see there is erosion around the joint, which is classically seen in septic arthritis. And in the third image, if you see, there is complete bone resorption and thinning of the cortex of the bone, which is classically seen in renal osteodystrophy. So that's it. When you solve the clinical MCQ, look into the other options also and look into at least images so that you will have an idea about the other options and also the differential diagnosis. If the same bit was asked in another way, you could be able to answer. And I might have solved this MCQ over 3 to 4 minutes, but this is just to explain you the art of solving a clinical MCQ. This entire process should be completed within 60 to 75 seconds in your brain. But how is that achievable? It is achievable if you practice clinical MCQs vigorously and also daily, and you need to make your revisions integrated. And you can be a master of solving the clinical MCQs if you practice the MCQs without fear and with the attitude of enthusiasm, and you need to feel like a real detective while solving the clinical MCQ, because that will give more energy while doing the MCQ, and also you will get an elated feeling if you decode the answer while doing the clinical MCQs. Okay, now let's quickly solve another clinical MCQ and let's see what we can get here. So an 85-year-old woman is investigated by her general practitioner by increasing tiredness which has developed over past 6 months. She has lost her appetite, feels constantly nauseated. She has lost about 8 kgs in weight over past 6 months. For the last 4 weeks, she also had complained generalized itching and cramps. She has been hypertensive for 20 years and she has been on antihypertensive medications for that time. She has 2 cerebrovascular accidents which have limited her mobility. She lives alone but uses Meals on Wheels service and goes to day hospital twice a week, and she has 2 daughters. On examination, conjunctiva are pale, pulse is 85 per minute regular, blood pressure 190 by 110 mm Hg, mild pitting edema of her ankles is present. Otherwise, examination of CVS and respiratory systems is normal. Neurological examination show left upper motor neuron facial palsy with mild weakness and increased reflexes in the left arm and leg. She is able to walk with a stick. Fundoscopy shows arteriovenous nipping and increased tortuosity of arteries. So from the history and examination, what are the points that I caught? So the clickbait points I have caught in this question is tiredness which has developed over past 6 months, and her loss of appetite and loss of weight over 6 months, and she had generalized itching and cramps. She's hypertensive since 20 years and her conjunctiva is pale, that means she's having anemia. Her blood pressure is 190 by 110 mm Hg and she's having mild pitting edema, and her fundoscopy shows arteriovenous nipping and also increased tortuosity of arteries. From this, I can clearly say that the patient is suffering from a disease that belongs to renal system. Yes. Why? The mild pitting edema is not due to cardiovascular system or respiratory system as given in the question. Then what is left? It is due to renal system. Now in renal system, what can be the disease she is suffering from? So let's look into the investigation so that we can find a clue to which renal disease she is suffering from. The relevant points in the investigation I have found is hemoglobin being 7.2 grams per dl, urea 862 mg per dl elevated, creatinine 8.6 mg per dl elevated, calcium being 1.94, phosphate being 3.4 and ALP being 423, and urine analysis having mild proteinuria and also hematuria, and blood film shows normochromic normocytic anemia. With all these things, one diagnosis that is striking in my mind is chronic kidney disease and patient might be in renal failure. Now let us see the options and let's see our diagnosis is there or not. Now look into the options. The options were acute kidney injury, lupus nephritis, IgA nephropathy and cerebrorenal syndrome. They haven't given CKD directly, but now how can we see which option is fitting into the history and also investigations? Let's go by exclude and decode method. First option, acute kidney injury. It can't be acute kidney injury because it's not an acute episode, because the patient is suffering from the episodes from 6 months and she's also having hemoglobin of 7.2 and she's having hypocalcemia, hypophosphatemia and in the blood film normocytic normochromic anemia. All these features are suggestive of CKD. If you know why the patients in a CKD will have normochromic normocytic anemia, because due to erythropoietin deficiency there will be delayed maturation of RBC, so it takes longer duration for producing normal RBC, so that is why the patient will have anemia, and the patient will have hyperphosphatemia and hypocalcemia because the kidney cannot excrete the phosphate, and also due to the decreased function of the kidney there will be decreased absorption of the calcium, which leads to hypocalcemia and hyperphosphatemia, which leads to the activation of the parathyroid gland and results in the release of parathormone, which will activate the osteoclast, that will eat away the bones and release calcium and phosphate again. But due to hyperphosphatemia, this phosphate goes and binds with the calcium, so it is very difficult to correct the calcium in a CKD patient. So that is the entire concept related to CKD, which is clearly indicated in the investigations. And let's move on to eliminating the acute kidney disease. Now here they have put a trap called cerebrorenal syndrome. Yes, most of you will answer it as cerebrorenal syndrome even though you know it is a CKD, because they have given in the history she is having a 2 CV attacks, and in the neurological examination also they find a abnormality. Now if you know what cerebrorenal syndrome, then definitely you won't go and fall for that trap. Cerebrorenal syndrome is also called as Lewis syndrome, which is an X-linked recessive disease. We don't have any family history suggesting. And also what are the CNS features that suggestive of cerebrorenal syndrome is intellectual disability and hypotonia. Anything mentioned like that? Nothing. And also in a cerebrorenal syndrome patient there should be cataract. Ocular manifestations are also important. So any of that symptoms or signs are not present in the patient, we can clearly eliminate cerebrorenal syndrome without falling for that trap. And now we are left with two options. One is lupus nephritis, another one is IgA nephropathy. Both can cause CKD and both leads to nephritic picture. But in the question, did we find any feature related to systemic lupus erythematosus? Do we have malar rash or discoid rash or synovitis or arthritis? Nothing related to SLE is given in the history, so we can clearly eliminate lupus nephritis and we can conclude that the answer is IgA nephropathy, and there you go, that will be the right answer, because IgA nephropathy is most common primary glomerular nephritis in an adult, which leads to end stage renal disease leading to renal failure. And again, I might have taken at least 3 to 4 minutes to solve this MCQ, but you need to solve within 60 to 75 seconds, and yes, it is possible. You can do that. You can master solving the clinical MCQs by practicing the clinical MCQs daily basis, and integrated revisions will make your brain sharp so that you will solve the clinical MCQs within stipulated time. So in the next slide, I'm going to show you something that is very important, which has lots of concepts and also interlinks, which will solve many MCQs. So you need to take a screenshot of it. Everything I have explained regarding the anemia and hypocalcemia and hyperphosphatemia is given in that slide. Go take a screenshot. This will help you in your revision. That's how you go pick up the points that are major clue for the answer. Do not fall into the trap created by the examiner. Be confident while marking the answer without any second thoughts. And there you go, you will be all set to score well. This should be your approach while doing a clinical MCQ. If you like this and want me to do a series of videos on me solving the clinical MCQ and explaining you the easy way, let me know. And my final point on this change in NEET pattern to clinical MCQ is, clinical pattern may be a time sucker, but they are the ones that can give you good score as the answer is right in front of you even if you don't look at the options. This way of the exam will change your attitude towards the preparation. You will be more cautious while doing the revisions. You will know lots of clinical aspects from all the subjects, and you will have the feeling like, oh, this can be asked this way. Oh, this topic can be asked that way too. Your perceptions do change. So after you get into PG, your approach will also be the same with the patients. This shows lots of pros with the change in the pattern. So do not panic. Do not think about the level of difficulty they are going to give this time. However the paper might be, whatever type of questions they might give, you are going to do great and you will do it right. Let's move with positivity. And that's all for today. If you loved this video and also the way I solved the clinical MCQ, then share this video with your friends and also do subscribe to my channel Dr. JTM. As I said, this month is going to be a golden month for the NEET PG aspirants from my channel and you don't want to miss any of it. I will come back with another great video. Till then, bye. See you again.